internal abdominal oblique. But for this one, the fibers can continue down here, and if you'll notice here, it's kind of hard to sketch in, is that the contribution of the internal abdominal oblique is brought into the spermatic cord to make the cremaster muscle, okay? Now, as you see up here, the internal abdominal oblique and the transversus abdominis kind of conjoin together to form the conjoined tendon, okay? So that gets a little bit better picture of how that comes together here towards the rectus pillars, right? So as you come into that layer down in the spermatic cord, it's kind of a combination of both layers, okay? You have transversus abdominis fascia combined with internal abdominal oblique muscle fibers to make that cremasteric fascia / muscle, okay? Purple here?
All, like it's coming through pretty much the external oblique muscle.
Yes, and we'll get to that part, okay? So purple is, what was the next deep layer? That's your transversalis, okay? All right, so that's your deepest layer there. And then pink's going to be?
Peritoneum.
Peritoneum, okay? So that's going to be useful over there in that section.
Wait, where's the transversus abdominis? Is there transversus abdominis?
Green.
Transversus abdominis.
External, internal, transversus, transversalis, peritoneum, okay? And then you've got your vessels coming from deep, which would be retroperitoneal, right? And then in through all of these layers down to the scrotum, okay? So things that we should take note of, we already took note of the conjoined tendon, okay? What would be this nerve running in between your internal and your transversus abdominis? Ilioinguinal, which is a branch of L1. What's the other branch?
Ilioepigastric.
The epigastric, and where would that be running?
Between the external and internal.
Between the external and the internal, okay? So that's things to know. I didn't put that on there because it's not as important. But one thing to note about the ilioinguinal is that even though it's coming down to meet up with the spermatic cord, is it going into the deep ring?
No.
No, it's not, because it's deep to the layers that are going to make the ring, right? So here you have your deep ring and dotted line to show back in the back, right? This is an opening in which layer? Transversalis, right? So here you have your deep ring, and then this dotted line here showing your canal out through here to form your superficial ring, okay? Does everybody see that?
Yeah.
Now, these two sides here, right? I didn't label them, put lines there, but what would these be? This is external abdominal oblique, but these two areas, what would this be? This would be medial crus. This would be your lateral crus.
Are those muscles?
It's just portions of the aponeurosis as it goes through, right? So what you have is you have your spermatic cord as it's pushing through, right? And as it's, well, let's just really think about it as the testes, right? As it's pushing through, to get through there, there's a separation. But what we have to do then is then strengthen that connection by wrapping fibers across. And that's these. These are your intracrural fibers. So when you guys see it in the diagram, you see those two separations and then fibers going perpendicular to that. That's your intracrural fibers. Underneath here, back behind the spermatic cord, what kind of fiber, what's going to be making, I kind of ruined this already for you guys by coloring them, but what fibers would these be made up of? External. And why does that make sense? Even though this is the back area, because if you look at this in 3 dimensions, this is behind the spermatic cord, right? So this is like, the spermatic cord's hanging there, those are the back fibers. And why that makes sense is because this whole thing is reflected back. So you have this reflected fibers of the aponeurosis of the external abdominal oblique. Does that make sense? Okay. So when you think of inguinal ligament, you think from your ASIS down to your pubic symphysis, right? Down to your pubic tubercle, right? What is the iliopubic tract then?
Whole area.
It's the same thing, but from the deep view. So if you have something that's from this side, right, you're looking at the external abdominal oblique's contribution to the inguinal ligament, correct? But if you're looking at it from the other side, you're looking at what's contribution to it?
Transversalis fascia.
The transversalis fascia. So if you're looking at it from the back, you see the iliopubic tract, which is made up of the transversalis fascia. Okay. So tomorrow I'll redraw this from the internal side, so you guys can do your triangles and triangles and painting and all that jazz.
So it's the same thing with different view.
Huh?
Same thing, different view.
Because it's the same connections, right, from your SIS to your pubic tubercle. Right? Okay. And why the iliopubic tract is important, and Dr. Cefali will probably bring this up again, is that when you're doing a laparoscopic surgery, you got to go in and then look back at it, right? So when you're looking for this triangle of doom and things like that, you're looking at it from the internal view, not from this view. Does that make sense?
Wait, when you're doing laparoscopic surgery on what?
On a hernia.
On hernia.
So if you go in there and you have this incision and you put your little camera in through there, it goes in deep, turns around, and looks at this from an internal, a deep view. Okay?
That's what you're fixing.
This is the same thing like when you guys took your thoracic cage and opened it, flipped up this way, right? Those internal thoracic arteries are deep at this point, but they look superficial to you because it's upside down. Okay?
What was the triangle of doom? And the
We'll talk about that later.
Don't worry about that.
Okay. It's important, but it's
Not right now.
Yeah, not today. Okay. So, let's take this first, okay? So now what do we have to do? We have to develop the testy in development, right? We have to pull it down through all these layers, right? And as we build all those layers down, that's how we build the scrotum and the spermatic cord. The spermatic cord and the scrotum are kind of continuous with each other, right? So, over here, all right? This is kind of like the easy book version of it, and this is the really simplified version. So this pink layer here, this would be your peritoneal space, right? So this pink line is your peritoneum. What is actually in your peritoneum?
Nothing.
Nothing, really. You don't have vessels, you don't have anything, right? Because we just finished that for the last exam, is none of your vessels actually transverse in the peritoneum. They're all wrapped by mesenteries or omentum, correct? Okay. So what we do is we move it to develop the testes, move it back retroperitoneal, correct? Can you leave it open for me? I'll make sure I close it before I leave. Okay. So we have to move it retroperitoneal, right? And what I don't have drawn on here until later is the vessels, right? Because where do all the vessels come from? Where's your blood supply and your venous supply coming from? Aorta, and your venous supply is going to the inferior vena cava, which are all what kind of peritoneal stuff? Retroperitoneal, right? So if we have a retroperitoneal source of vasculature, they have to stay retroperitoneal. Okay? So what we're going to do is we're going to develop the testes, then we're going to start dragging it down, right? We're going to invaginate a portion of the peritoneum, which we call a processus vaginalis. Okay, so this is your processus vaginalis. It's a continuation of the peritoneum down into the scrotal sac. Right. As we continue to move the testes down, now what we want to do is wrap the testes in this little peritoneal layer. Right. But what happens here is what we had a single layer here. If I pinch off right here, right, connect those, and then wrap it around what I have now. It's a double layer. This is just like when we refolded the greater omentum. You know, we made a 4-layer sac out of it. Same kind of idea. So now we've wrapped this around the testes, and now you have, in essence, a peritoneum for the testicles. So you have a deep invested layer, which would be like a visceral layer, and then a parietal layer. So what's that parietal layer called? And what's the deep layer called? Tunica albugini. All right. Does that make sense to you guys?
Okay. Was testicle and intraperitoneal, then became
And then it became
retroperitoneal, and then it just kind of doubled back in on itself, but it didn't go back in.
It's not retroperitoneal. Now it's still retroperitoneal. Right?
Extraperitoneal, I guess. Is that what
It's extraperitoneal.
Is that what it is?
Yeah. Until we get it down here and then wrap it all the way around. So what, in essence, this back portion is almost similar to, you guys have all heard this before, but the hilum of the lung, same concept. I've got to get all the vessels and this, specifically, which is your ductus deferens. We have to get that in to the testes, correct? So when I do that, I have to leave a space open. So what you guys don't see in space is this is actually like that, right? So it's wrapped all the way around the testes except for in one small portion where we can put the vessels in to get to the testes. Does that make sense? Yeah. So, and it's just as simple as all that is. Once we do that, we can push that, invaginate that through all these layers, and as we're doing that, we're picking them up as part of the spermatic cord and down into the scrotum. So if we work out from the inside out, right, what was that first layer we just wrapped around? The peritoneal capacity, so we'll call it the two things, right? The tunica albugini, inea is the deepest one. That's your visceral peritoneum. And your parietal would be the tunica vaginalis. Okay, so I have them here as one layer, and the epidermis there, but just for the sake of conversation, it's two. Okay. Right. The next layer out is going to be what?
The transversalis.
It's going to be a transversalis. So that's going to make your internal spermatic fascia, right?
Is that what's called?
to your internal spermatic fascia. Next out is this brown layer, which is a combination. You should probably put some green hash slash on there, but it's a combination of your internal and your transversus abdominis, right? Which we would call the cremasteric fascia. Okay, does that make sense? That's your brown layer there. Then the next layer out is going to be your external abdominal oblique, which is going to make your external spermatic fascia. Okay, and then blue and black are kind of, I had another diagram, it wasn't the best, right? Your blue is going to be your extension of, what's that layer of subcutaneous tissue that you guys talked about up here? Scarpus. So as scarpus continues down into the testicle, that becomes your dartos fascia. There's debate on whether the campers is also down in there as well, but the dartos has the function of shriveling and wrinkling around the testicles for heat preservation, versus the cremaster muscle, which is dragging the testicles back up towards the body. So the whole point of this is to keep them away from the body so they can keep warmer or cooler. Cooler, right? Well, let's say things are getting really, really cold, right? In Philadelphia, I know this response. And then you got to drag everything back up in, all right? So this is heat preservation, okay? And then you have skin on the outside. So that's your scrotum. It's that simple. It's just the same layers as up here, down here.
So the cremaster is done by somatic. So wouldn't that mean we have control over that? Then, like,
that's what Dr. Kratz and I are looking into right now. I would assume, just because it's part of a somatic muscle, I think there's probably still autonomic once it splits off into the cremaster, but don't worry about that right now.
Sumo wrestlers can do it. That's what I've heard.
Really?
They track them like on when they need to.
Cool party trick. but where would your autonomic innervation to your dartos fascia be? Because dartos has got to shrivel and what nerve do we discuss that's going to be serving up in that area? The hypogastric doesn't need down there. Ilio-inguinal. So your visceral afferents from your testicles could be carried up by your ilio-inguinal. Because remember before we said our visceral afferents travel with either our sympathetics or our parasympathetics, right? But in this case, the source is the ilio-inguinal, which is coming from where? L1, which is above the pelvic pain line. So, it's above T12. So, if you've got visceral afferents traveling all the way back up there, that's why when a guy gets reprimanded in genitals, he can have referred pain back to his lower back. Does that make sense? Alright. So now we have all the layers. We have all the layers of our anterior abdominal wall. We have the layers of our spermatic cord. And we have the layers of the scrotum, right? What are the contents of the spermatic cord that are meant? What's this blue jelly job?
the vein,
The plexus. It's epiniform plexus. And this is not only is it draining the testicles, but it's also a heat exchanger. Okay.
What's the name again first?
Epiniform plexus. Yes. And that's how everybody does heat. If you guys ever do, has anybody here done comparative phys? This is how birds keep their legs warm in cold water. They just exchange heat really, really well between the veins. Okay. And then what else is in there? What's the little brown dude? The ductus deferens, right? You really need three things straight to the testes. You need blood, you need veins from it, and then you need the ductus deferens, right? Okay. There's nerves and stuff like that. There's, like I said, the sympathetics and whatnot. That's not as important as those concepts. All right. And that's it. It's not that hard. So think in relation to when your ductus cephali will probably cover a lot about your anterior wall, posterior wall, roof, and floor of the inguinal canal, right? The consequence of all this is that when you're opening that up and you guys are moving things around, right? There's kind of like a little box that you're making for the spermatic cord, right? And depending on where you are in it, those components are different. Okay? Tracking? Yeah. Did you feel a little bit better about this?
Oh my God. Okay, quick question. You did an amazing job, by the way. Thank you so much. Can you, like, what's usually like a taggable thing? I hate to be like asking that kind of question.
This guy.
I know, whatever. I want to know. I mean, like, I want to be able to study.
Taggable stuff is quite frankly, I wouldn't say that it would be very easy to tag any of this,
Yeah.
any of these layers. You need to know that that's like lecture material stuff to know what the layers are, or what they are and where they come from is really important. But superficial ring, deep ring, those are highly taggable. The contents going in, this is absolutely taggable. All the contents as they come into the cord, because you should be able to see where the where's the testicular artery on the right side coming from. The aorta, right? Where's the testicular vein coming from on the right side? What? Inferior vena cava, right? Where's the testicular vein coming from on the left side?
Not being renal.
Your renal vein. That's a huge one that usually goes for that. And I was saying this to people before, so if you have a block in your left renal vein, right, which vessel is going to become swollen?
Left
Your
testicular.
left testicular vein. And that wouldn't happen on the right. It would happen on the right because your testicular vein is coming off the inferior vena cava. Yeah, your left is coming from. Okay. You guys, tomorrow is posterior abdominal wall and lumbosacral plexus, right? So you guys are going to see those nerves that you guys found in here, your ilioinguinal and probably your iliohypogastric up here, and the lateral femoral cutaneous, right? All that stuff you saw from this side, you're going to see it from the back body wall and where it comes out from the spine. What do we have?